Preterm labor with intact membranes. The differential diagnosis between intraamniotic infection and sterile intraamniotic inflammation. There is no financial disclosure. Preterm birth is a leading cause of prenatal morbidity and mortality worldwide. Preterm labor with intact membrane is a syndrome caused by multiple pathological processes. Intraamniotic inflammation is a major cause of preterm birth and neonatal morbidity and mortality. Recent evidence suggests that the two causes of intraamniotic inflammation, whether it's microbial or sterile inflammation, can be diagnosed and treated in humans and in animal models. The most powerful test to identify intraamniotic inflammation is amniotic fluid interleukin 6. Our study was conducted to determine whether the amniotic fluid IL-6 concentration can be used in the differential diagnosis between microbial associated intraamniotic infection and sterile intraamniotic inflammation. Our study is a retrospective study that included two independent cohorts of patients with preterm labor. Singleton pregnant women with preterm labor and intact membranes underwent transabdominal amniocentesis, where amniotic fluid samples were collected for microbiological studies. Amniotic fluid was analyzed for microorganisms by using cultivation and molecular techniques. The cultivation techniques included culture under aerobic, anaerobic conditions, and also for genital mycoplasmas. And the molecular techniques included broad-range PCR. IL-6 concentration was determined by ELISA. Intraamniotic inflammation was diagnosed when the amniotic fluid IL-6 concentration was more than 2.6 nanogram per milliliter. Microbial associated inflammation was diagnosed by a combination of bacteria and intraamniotic inflammation. Sterile intraamniotic inflammation was diagnosed if inflammation was present without the presence of microorganisms. ROC curve analysis was used in the first cohort that included 142 patients to identify patients with microbial associated intraamniotic inflammation. The results were tested in the second cohort that included 166 patients. Patients with identified bacteria without intraamniotic inflammation were considered contaminated. Results. We can see the clinical characteristics of patients included in each cohort regarding the maternal age, body mass index, the concentration of glucose, white blood cell count, and we can notice the prevalence of no intraamniotic inflammation is 62% in the first cohort and 62.7% in the second cohort. Sterile inflammation is the next most common finding among this group of patients, 27% in the first cohort and 22.9% in the second cohort. And the microbial inflammation is the least common entity, representing 10.6% in the first cohort and 14.5% in the second cohort. This figure is showing the amniotic fluid IL-6 concentrations in patients with spontaneous preterm labor in the first cohort that included 142 patients. Patients with microbial associated intraamniotic inflammation had the highest amniotic fluid IL-6 concentration with a median of 118 nanogram per milliliter compared to the other two groups of no intraamniotic inflammation or sterile inflammation. And amniotic fluid IL-6 concentration equal or more than 9 nanogram per milliliter was able to identify all patients with microbial intraamniotic inflammation, although it also identified patients with sterile inflammation with a false positive rate of 61% to diagnose microbial associated inflammation. All patients with amniotic fluid interleukin 6 concentration between 2.6 and 9 nanogram per milliliter were diagnosed with sterile inflammation, and this IL-6 interval identified 38.5% of patients with sterile inflammation. ROC curve of amniotic fluid IL-6 concentration in patients with spontaneous preterm labor in the first cohort that included 142 patients to identify microbial associated inflammation. We can see here when we use amniotic fluid IL-6 equal to or more than 28.9 nanogram per milliliter, it had a sensitivity of 87% and a specificity of 97% to identify microbial associated inflammation, with an area under the curve of 0.97. This figure is showing the amniotic fluid IL-6 concentration in patients with spontaneous preterm labor in the second cohort that included 166 patients. We can see here at amniotic fluid IL-6 of 9 or more, the test was able to identify all patients with microbial associated inflammation. And between 2.6 and 9, it identified some of the patients with sterile inflammation. So the results were reproduced in the second cohort compared to the first cohort using similar CAT values. This table is comparing the different CAT values identified and applied to each cohort. We can see the amniotic fluid IL-6 more than 28.9 nanogram per milliliter for diagnosis of microbial associated inflammation had a sensitivity of 87% in the first cohort and 83% in the second cohort, with a specificity of 97% in the first cohort and 96% in the second cohort. A positive likelihood ratio of 28 in the first cohort, 20 in the second cohort, and negative likelihood ratio of 0.14 in the first cohort and 0.17 in the second cohort. Amniotic fluid IL-6 more than 9 nanogram per milliliter identified all patients with microbial associated inflammation, with a false positive rate of 62% in the first cohort and 49% in the second cohort. All patients with amniotic fluid IL-6 between 2.6 and 9 nanogram per milliliter were diagnosed with sterile inflammation. And this IL-6 interval identified 38.5% of patients with sterile inflammation in the first cohort and 39.5% of patients with sterile inflammation in the second cohort, which is around 40%. Our conclusion is amniotic fluid IL-6 concentration can be used for rapid assessment and diagnosis of microbial associated sterile inflammation. Thank you.